Hey everyone, and welcome back to the channel. Today, we're diving into a super important, high-yield topic for your exams: opioid toxicity. We'll break down a classic clinical vignette that you're almost guaranteed to see in one form or another. Ready? Let's get started. Picture this scenario. A full-term newborn is delivered. The mother has a history of opioid use disorder and was maintained on methadone throughout her pregnancy. At just 2 hours of life, the infant isn't feeding well, is lethargic, and has a very slow respiratory rate of about 20 breaths per minute, with some periods where they even stop breathing, which we call apnea. You also notice the infant has pinpoint pupils, and their oxygen saturation has dropped to 90% on room air. So, the big question is, what is the most likely cause of this infant's respiratory depression? Is it neonatal abstinence syndrome, or NAS? Or is it something else? If you're thinking it's direct opioid toxicity from the maternal methadone, you are absolutely correct. Here's why. Methadone is an opioid that easily crosses the placenta. It has a long half-life, which means it stays in the body for a while. So, when the baby is born, the methadone is still active in their system. This persistent opioid effect leads to acute respiratory depression very shortly after birth. Exactly like we see in our case, within just a couple of hours. The classic signs are all there: lethargy, slow breathing, and those pinpoint pupils. Now, let's contrast this with neonatal abstinence syndrome, or NAS. This is the withdrawal syndrome. NAS doesn't typically show up until 24 to 72 hours after birth, sometimes even later, depending on the substance. The symptoms are the complete opposite of what we just saw. Instead of being lethargic and breathing slowly, an infant in withdrawal is irritable, has tremors, increased muscle tone, a high-pitched cry, and often breathes very fast, not slow. So, the key pearl to remember is to distinguish between acute toxicity and withdrawal. Toxicity presents with respiratory depression and constricted pupils, while withdrawal presents with agitation and fast breathing. This neonatal scenario is just one of several ways opioid toxicity can be tested. You need to be prepared for questions about overdose in an adult, complications in the perioperative period, issues with polypharmacies, especially when opioids are mixed with other sedatives, like benzodiazepines, and questions about the mechanism of action. No matter the scenario, always be on the lookout for that classic triad: hypoventilation, which is slow and shallow breathing; meiosis, or pinpoint pupils; and a decreased level of consciousness. You should also be aware of the higher risk groups. These include the elderly, patients with obstructive sleep apnea, and anyone taking concurrent sedating medications. The risk of respiratory depression is much higher in these populations. And of course, what's the reversal agent? You got it, naloxone. Knowing when and how to use naloxone is crucial, both for your exams and for real-life clinical practice. It acts as an opioid antagonist, rapidly reversing the life-threatening respiratory depression. So, to recap, for your exams, focus on recognizing the classic triad of opioid toxicity. Understand the difference between acute toxicity and withdrawal, especially in newborns. Be familiar with higher-risk patient groups, and remember that naloxone is the go-to reversal agent. These concepts are incredibly testable, and understanding them well will definitely score you points. That's all for today's deep dive. I hope this breakdown helps you feel more confident about tackling these questions. If you found this video helpful, please give it a thumbs up. And don't forget to subscribe so you don't miss our next high-yield review. Drop any questions you have in the comments below. Thanks for watching, and I'll see you in the next video.